So I'd like to thank you for being here today. It's a real privilege to introduce our keynote speaker today. Professor Suzanne Crowe is a pediatric intensive care unit an anesthesiologist and is also president of the Medical Council. In 2025, she published this book called Intensive Care, True Stories of Healing, Heartbreak and Hope from Inside Irish Children's Medicine. It has messages which will resonate for many healthcare workers, but also for anybody who's been a patient and for parents of children who have been ill and their families. There are nuggets of wisdom and advice in this book for everybody. Suzanne writes, the life of medicine is not knowledge, it is experience. And based on these words, we've asked her to come today to give a talk about advice to her younger self. We're delighted you could join us in your busy schedule. Thank you very much, Suzanne.
Thank you, Seamus. Good afternoon, everybody, and thank you very much for the generous invitation. When Seamus got in touch and asked me to come and talk about this topic, I thought, well, I probably need several hours to go over all the things that I've learned over the last 30 years. But I won't take several hours. Yesterday evening, I was talking to my mum, and I told her that I was going to come to this particular meeting to speak. She's always a bit bemused when she thinks of me doing things like this. And she said, "But you don't know anything about cancer." I said, well, fortunately, I'm going to touch on, I suppose, my own perspective of the hidden curriculum, which I know is an important theme for the conference today. And I'm going to stay away from the theme of cancer, which my mother has rightly pointed out I don't know a huge amount about. But what I did notice, and I was delighted to listen to all the trainee presentations, what I noticed was that many aspects of the hidden curriculum were touched in the trainee presentations, including communication around the end of life and self-care, particularly at that important time. So it's wonderful to see these aspects, I guess, gaining prominence within our profession. Because when I look at the Medical Council information, and now that I work in that part of medicine, I notice that more than 60–70% of the significant complaints that come across my desk have aspects of the hidden curriculum in them. And particularly where that overlap between professionalism and the hidden curriculum comes into play. So I have learned many things over the 30 years, and I'm just going to give you my perspective on them now, but also really focusing on that big leap that I made in order to move into the role of President of the Council, because that was a particularly learning kind of time for me. This is, I suppose, a list of all the things that I've done in the last kind of 30 years. But what you don't see here is the things that I failed at. And there was many things. I failed in second med anatomy, which kind of derailed my potential as a career in surgery. I also applied for several rounds of HRB grants, and I never got them. So this is something within the hidden curriculum to think about, which is getting comfortable with the idea that we will fail at many different things. And when we put up a bio that is meant to impress, obviously, we should look to kind of see, well, what's behind that? What about the things that you didn't actually manage to do, but you learned a huge amount from, and you use then as kind of fuel for your next endeavor? Because that kind of attitude is much more helpful to us within medicine than that streak of perfectionism that a lot of us have, and Brendan Kelly may well have referred to that this morning. But getting comfortable with the idea that when we're doing something new, we're going to be really bad at it. And we tend to hate that. And I was out on the roads over Christmas doing driving practice with my daughter, And I was kind of reminded of how it's awful to be a learner at something. I mean, every part of your atoms kick against that idea because we like being good at things. That's kind of part of our makeup as doctors. So failure, and then taking on new things, accepting that you're going to be bad, and that you're going to need help, are certain aspects that I certainly wish I had appreciated. Now, I'm not going to scare you or bore you too much talking about regulation, but certainly when I was a trainee and a medical student, certainly as a trainee, I didn't really have much awareness of regulation that's kind of like a bubbling stream in the background of all of our practice. And I would say that we should get a bit more understanding and knowledge around these structures that hold us in terms of our training, our experience, where we go, different hospitals, how fellowships are accredited. We all need more knowledge around that, partly so that we can plan better, because even though you might be on a training scheme, or you might be trying to get onto a training scheme, or you're newly appointed as a consultant, you are the author of your own life adventure. So you want to take the pen out of other people's hand and write your own story in this regard, because you are the author. And in many ways, we can't really do that when we don't fully understand how these structures work. And it's one of the reasons why I did decide to get involved in the Medical Council, is because I was bothered by the fact that I was scared of it and I didn't kind of understand it. So gaining understanding of these things is really helpful, and I wished I'd certainly known that. The reason why I put this up is because it shows the different roles of a member of council. And if you look down the list, you can see that most of these are not covered in your average training program. We don't tend to have training around financial accounting, balance sheets from major organizations. We don't really understand the fiduciary, the financial obligations of being a director on a board, all of these things. Now, I'm sure most of you are thinking, well, I haven't the slightest intention of going anywhere near the Medical Council, but there will be other roles that you will take on within your training, possibly, if you become like an NCHD lead, or you're delivering a service and you want to introduce a new aspect within the outpatient department. You may well lead a speciality in the future, and you may well come into a management role. And all of these kind of aspects of your role will become much more important. And so having an awareness of them from a much earlier stage will just have your antennae lit so that you can pick up a lot of the skills that you need along the way. Because none of these skills are impossible. None of this knowledge is out of your reach. And certainly from the trainee presentations I've heard today, there is nothing out of your reach in terms of knowledge, but it's just knowing that it's something to think about. When I decided to come into this role, and when I went for it, what I wanted to do, I had a very specific vision. And I'm going to come back to that in a second. And it was to do with being more compassionate within regulation. And that's picked up in our strategy. But what I suppose I began to realize was that certain skills were going to be needed to take me into this role that I didn't actually have. And so this, I suppose, introduced this kind of idea that as a consultant, and I had been a consultant for maybe 20 years, I think, at that stage, before I moved on to the council, I think I thought that I had most of the skills and the knowledge that I needed in order to move into the role of president of council. But it became clear to me as an ordinary member that that wasn't the case. And again, this was not something that the training schemes would have talked about, was that you would need to continue to develop new skills to take you further. I think I thought it was a kind of a, you're trained and you're done situation, and maybe that was naive of me. But within medicine, as different avenues open up for us as doctors, it's about acquiring new skills. And so I've very luckily happened upon a mentor and who agreed to coach me to come into the role of president. And I know that mentorship is something that you're going to look at a little bit in the afternoon as part of the hidden curriculum. And mentorship, of course, is a relationship, and it's being a mentor, and it's being a mentee or being mentored. So there's two aspects to think about depending on where you are in your career. So my mentor was a retired auditor from PwC, and so he had a very forensic way of looking at things. And he went through all of the various aspects that I didn't know, I suppose. So the fact that I didn't really have much knowledge about corporate governance or internal governance. I didn't really know about the statutory obligations that the council had in terms of reporting to the Department of Health and reporting to the public. I didn't really have any legal knowledge. So all of these kind of things. And then, leadership and communication and working as a team. Because I was used to working as a team within the intensive care unit, but it's a bit different when you're working as a team with a much more diverse makeup of people. So he helped me. Well, firstly, he very humbly made a list of all the things that I wasn't great at, and then he helped me work through them over about 18 months to address that. And that has been a really interesting period for me, but it also means that when Seamus asked the question of what did you wish you knew when you were a trainee, firstly, I wished I'd known that that was an opportunity that might actually open up for me in the future, if I wished. And secondly, that I was going to have to continue to build and continue to go back and be absolutely rubbish at something and ask for help and then go on and become better and move on. And I really wish that I had known that, because I think I would have been better prepared. We do pick up aspects around leadership and management in the guide. That's just a picture of the guide to conduct and ethics. We do pick that up because we're very aware, actually, within the council, that increasingly our profession and the healthcare system asks us to take on additional roles. Now, people have varying views as to whether that's a good thing or not. And that's not a debate we'll have today. But certainly, if it's something you're thinking that you might like to do, then you probably need to look at additional skills. A lot of what we do is grounded in trust, and that's true no matter what other kind of role you go into. You will find it very interesting that members of the public and members of other professions will look to you as a doctor for that kind of trust and competency. So we have a very strong base to start from when you're looking to move into a new area and build skills. But it's obviously very important that we don't take that trust for granted. So these were the three things that I suppose I kind of identified in moving into a new project and taking on the role of president. And the first was this idea of keeping a beacon. So when you take on a new project, and you would do this anyway as part of your research, you outline your objectives. But you can do that for other projects that you take on. If you're changing career, or if you're moving role, or you're changing hospital, what's your beacon? What's your vision for that period of time? Because many other people around you will put obstacles in your path, and you'll get distracted by other issues. But if you have a core theme that you can come back to sense check what you're doing and where you're going, it can be really helpful. So for me, during this time period, I wanted to address that narrative that had grown up over the last few years that in some way doctors were against patients and patients were against doctors, because I think it's very damaging and nothing good can come of it. And I want to try and bring us all back onto the same page where we all want the same thing, which is great healthcare. I had to do a lot of leaning on the knowledge of others. So pretty much every meeting I go to, I have a brief. It's been prepared by people who know far more than I do about things, and I read the brief. And a lot of the engagement is about presence. And listening actively and being there. And so these are all skills that you already have, and you can acknowledge them. Developing new skills, as I said, and then this idea of taking on leadership roles. So just coming towards the end, you'll be glad to hear, it does take several years, I suppose, to plant the seeds of the kind of behaviors that you want to embody, I suppose. You know, it's not something you specifically think of when you're a medical student or a trainee, but to think about what kind of doctor you'd like to be in the future. And a lot of that we do by role modeling. So we look to see what's the kind of leader I would like to be, what's the kind of doctor I would like to be. And you see people along the way and you think, I really like the way that person communicates with their team. I really like the way that person pulls up a chair, sits down, listens to the patient before asking questions. So we see these kind of behaviors all the time, and we need to tuck them away in our minds and think, yeah, I like that, that's what I'm going to be like. And then we do see some less good stuff, and you have to actively push that away and say, you know, I'm not going to be like that, that's not for me. So, as I say, it takes a long time to build up because it's the small, consistent acts that really build your credibility. And certainly as an anaesthetist and an intensive care doctor, I find this a lot because we're 99% not a heck of a lot is going on, and then 1% utter crisis and chaos. And your team around you and your colleagues that you want to be performing to their highest, as you want to be performing to the highest yourself, they will be there for you when you have created this psychological safety and you have worked with an atmosphere of compassion and kindness. They're there for you then. And you find that your team works much better and the crisis isn't as much of a crisis as it might have been. Self-care and recovery is another very important aspect to build in, and to this day, I have to consciously schedule in time for recovery, but that's where you'll do a lot of your thinking as well. And one of the busy aspects is, or one of the aspects of our roles clinically and not clinically, is the fact that we're all so busy. We have very little time for reflection and for thinking. And so building in recovery time with time for thinking is very important. And again, that's not something I would have seen earlier on. I thought it was a good idea to have a diary that was absolutely chock-a-block, full of, you know, theatre lists and days in ICU and nights on call and research meetings and all that kind of thing. Every minute accounted for, and then a few minutes for my poor long-suffering family. And actually now what I do is I try and schedule in once a week or once every 2 weeks a day where I protect my time. I may still be doing a theatre list, but I deliberately don't have a trainee with me that day, and I do it on my own. I don't talk to a heck of a lot of people other than the team and the patient, and I'm kind of in my head, and I don't answer emails, and I don't answer the phone unless it's an emergency, because it's trying to protect your mind so that you can get some thinking done. Things we can start today, and I suppose I wish somebody had given me a list like this maybe 20, 30, 40 years ago. It's this idea that you build the seeds now, you can start this today, and once you start getting a few extra skills and awareness of the skills, the development is really exponential. And it really means that you can move very quickly because you have such a strong base in terms of your communication skills, your knowledge, and your ability to learn very quickly. Every time we speak, we show people around us what's important to us. This is not something I have come up with. It was said to me a couple of months ago by a colleague, and I just thought it really summarized our attitude that we should have as we go out into the world, and you could argue at home as well. But every little side comment that has said, without thinking, every text message, all of this, it's all transmitting an image and a perception of you as a person and you as a doctor. And so it's to kind of maybe just manage that and think about it a little bit more. I pick up with it on further down on the list when I say, be careful about email. And as I say, I could do a whole podcast episode on what I've learned about email. Email is a very powerful tool. It's also a very important tool, obviously, in terms of communication. You can do a lot of really good work in fostering relationships through email, but you can also do a massive amount of damage, and pulling it back and repairing it is really, really hard. So learning a kind of an etiquette around email, and I imagine there's an AI aspect to this that's coming down the tracks. Maybe AI will just hear my thoughts and translate them into email, and that would be a big problem. But I think email is definitely something to be careful of. Showing up and going to meetings in person. I appreciate it is a bit of a pain and it can be an expense, but there is nothing like meeting people outside of the clinical space to actually build relationships. And as I say, those relationships will be there for when you need them. I'm very strong on keeping emotional connection, and I realize that that's not something that works for everybody, because traditionally, and certainly from the era that I trained in, we were told to kind of hold ourselves back a little bit from the emotion. I have found it more useful, and it gives me more longevity in an intense profession to actually lean into it and to be able to say to families, like, I'm so upset and I'm so sad that I have to give you this news. Not making it about you, clearly, but demonstrating to families that we are hugely impacted by this work. And I did see that was picked up in 2 of the trainee presentations. We're massively impacted, so why are we pretending we're not? We're not doing ourselves any favors. So I would say lean in, but I appreciate it doesn't work for everybody. Identify your skills gap and just go after it. Go after it. And as I say, it won't take you towards regulation, if you're lucky, but it might take you somewhere else. And so have a think about that and embrace your creativity. And that's very much connected to the thinking time, because when you're being creative, be it painting, writing, whatever, you'll often find that the answer to an issue you've been kind of struggling with work-wise will actually drop into your mind. So they're very connected. So they're kind of the ideas that I didn't really consider when I was a trainee. Nobody around me necessarily spoke about this, and I kind of wish that I had heard about. These are ways to keep in touch with the Medical Council, should you wish. And thank you very much.
Thank you. Please sit down. So thank you very much, Suzanne. I was really struck in your book. You had a line about that patients are often surprised about how much time we spend thinking about them when we're not there. That really struck me as a statement of the obvious in one way, but also it was like a statement of a hidden fact also, too.
I think mostly I just state the obvious about a lot of things. We spend a huge amount of time. You're standing at the side of a rugby pitch watching your kids play rugby, but actually you're fretting about you know, how long it's taking for the histology result to come through on a patient, and is there somebody you could call to maybe hurry things up. It's kind of bubbling along in the back of our minds all the time, and I'm not sure it's possible to shut it off completely.
Yes.
And so we should just talk about it and you know, put our heads together as to ways to deal with it, and also to have a relationship with our colleagues that we can say, my mind is absolutely fried right now. I need to take a day off. And that you have the kind of relationships with your colleagues that they're like, we see it. And I have a colleague who, you know, definitely gets a bit crazy at times, and we do pull her into the office and go, you seriously need some time off. And it's meant in a kind and supportive way. And she'll give off and she'll stamp out of the room, but she will take the time off.
I'd love to. I think this conversation could go on all day, but in the interest of time, I think I'd like to acknowledge a wonderful talk, a really insightful. I thought your second, not the medical counsel, how to keep in touch with them, but the one before that about advice to my younger self was something that might go into your next book. Will be very valued.
Thank you.
Thank you very much.
Will I leave?
Good afternoon. My name is Michael McCarthy, and this is Dr. Anne Fortune. Today we will be chairing the next session. Just a quick note, if there are any judges from the oral session who still have a scoring sheet that I don't have, if you could drop it off to me after this session, that would be very helpful. But onwards into the multidisciplinary tunnel, we've got a stellar lineup of speakers who cover a broad range of perspectives from the full breadth of cancer care in Ireland today. And this, in the interest of time, we might go through their talks, and we have a panel section at the end where we'll take any questions for the speakers. First up, representing Allied Health, is Dr. Afric O'Sullivan.
We're starting with the broadest sense in the fact that it's not even really medically connected. We're really focused on nutrition for my talk. So I'm delighted to be able to give my perspective on what's happening in nutrition research in this case. My own background is, or my main focus for my research is personalized nutrition. But really over the past 4 to 5 years, like many other disciplines, sustainability is a really key element of what we're doing in nutrition. And so I'm really trying to understand the implications of changing to what would be considered a more sustainable and healthy diet for all. And that means taking a lot of different things into consideration. And you'll begin to see that as I go through my talk. I'm conscious that I could actually stay talking all day, so I've set a timer for myself. I don't think I will get through my slides in 10 minutes, but I'm happy to talk through the kind of later aspects of the research and where it has gone in the panel discussion afterwards, because I think it's actually one of the most interesting elements of it. So just to get us started, we're all aware that we're living in a world that's under pressure. And one of the problems from a nutrition perspective is that our food system is really contributing to that. So you can see some stats here in terms of the impact it's having on several environmental metrics, including greenhouse gas emissions being just one, but that's the one that I'm going to refer to because it's used as the primary outcome measure in my own research. At the same time, we've got a growing global population, and we still have huge problems with both undernutrition and overnutrition. So we've got this hugely complex system that's under massive pressure, and it's getting worse. And so one thing, or one element we need to look at is how we produce food and also how we're consuming food. And so I'll start with a quick definition of what is considered a sustainable and healthy diet. On the top right-hand corner of the slide, you can see the UN FAO definition. It has 4 elements to it. It must have a low environmental impact. It must provide nutrition security and health for all. It needs to be culturally acceptable and accessible. And this is a critical one that I will come back to at the end of the presentation. And it needs to be economically fair and affordable. On the left-hand side, you can see an adaptation of that in the Eat Lancet diet, which was a diet that was published in 2019 called the Planetary Health Diet. And I've used this as an image to show kind of what a sustainable, healthy diet kind of looks like, because it provides it kind of nicely in this plate format. And what I want you to focus on is, this is a representation of what different food groups are contributing to total energy intake in a sustainable, healthy diet. And you can see the blue slice and the dark red slice are animal source foods, the red being meat and the blue being dairy foods. So about 85% of our energy intake is coming from plant-based sources in this type of sustainable, healthy diet. If we focus on protein intake specifically, the Planetary Health Diet is recommending about 25% of our protein should be coming from animal source foods, and that about 75% or 3/4 is coming from plant-based foods. If we look at Ireland and we look at our National Nutrition Survey data, we're almost the opposite. We're about 2/3 animal and 1/3 plant at the moment. So we know that there is a way to go to be in a position where we're following something that reflects the Planetary Health Diet in this case. And I should say, this is just one example of what is considered a sustainable, healthy diet. So where are we in terms of our existing healthy eating guidelines, and how are we doing in terms of adhering to those? So looking at the top left-hand corner, this is our the food pyramid in Ireland. And actually, from a kind of a plant food perspective, we do quite well. We recommend a base of whole grains and fruits and vegetables. Our dairy recommendation is moderate. It's slightly higher than the Planetary Health Diet, but not too far away from it. But the challenging shelf is that yellow shelf, so it's the protein shelf, where we're recommending 2 servings of protein foods, and that they should be from, we should be getting our foods from a mixture of foods on that shelf, So that means it's coming from meat, from fish, and from plant-based proteins. The difficulty is that most people's interpretation of that is that they're mostly consuming the animal-based foods from that shelf and not so much of the plant-based foods. And one of the points that I make in a lot of my presentations is that if we actually look at what we should be eating from that shelf, if we eat a combination of foods from the shelf rather than just meat only, then we're actually fairly close to a sustainable, healthy diet. And I show that in the bottom line of the table on the right-hand side, in that if you followed it and you eat at the recommended serving size, which is 50 to 75 grams, I'm going to come back to that point as well, you'd be consuming somewhere between 400 and 600 grams of meat per week if you were varying your choice from that shelf. Bottom left here, and I'm not sure what is happening to my slides, but the colours shouldn't be behind this. As part of the My Planet Diet study, which is one of the studies I'll talk about now, we looked at how many people are meeting the healthy eating guidelines. And it's difficult to see here, but essentially about 30% are meeting the fruit and vegetable recommendation, about 20% meeting the whole grain recommendation. Dairy is our lowest in that people are not meeting the 3 servings of dairy that's recommended. Only 10 to kind of 13% are. But actually what we wanted to do with this was work out if people followed the healthy eating guidelines, would they have a more sustainable diet? And again, reminding you that greenhouse gas emissions was our metric here. If you look at the bottom right-hand figure, the striking thing, first of all, is that only 10% of our cohort were meeting 4 or more recommendations. And of that, only one of them were actually meeting 5. So it was about 10% meeting 4 or more. 90% were meeting 3 or less. And 42% were meeting 1 or less of the recommendations. But as I said, the key question was, if you follow recommendations, are you consuming a more sustainable diet? And you can see from the figure in the bottom right that yes, you are. You can see that 10% bar, that dark green bar, is much lower in terms of the greenhouse gas emissions, which is the metric on the y-axis there. So essentially what I'm saying is that we're not too far off a sustainable healthy diet if we look at our own food pyramid. But the difficulty is that we're not following it. If we did follow it, we would be eating a more sustainable diet. And this was very much the foundation for what became the My Planet diet. I'm jumping several slides here in that we went through about 6 months of developing what we called our My Planet Diet intervention diet, which was Ireland's version of a sustainable healthy diet, essentially. And I'm just presenting it to you here so that I can kind of move quickly to the results. I'm going to point out the key food group changes relative to our existing healthy eating guidelines, the first being the meat recommendation. So instead of saying have 2 servings from that protein shelf, we said specifically you can have 3 servings of meat per week. One of those can be red meat, but your serving size is 140 grams, which we know from research is an average portion size that somebody puts on a plate. So instead of telling somebody that they can have 2 servings per day, we're telling them they can have 3 per week at the serving size that they're usually serving themselves. Because typically, if they're told to have 2 servings per day, they're actually having 2 140-gram servings, which is kind of doubling the impact then from that kind of environmental perspective. The second was plant-based protein. Again, from national data, we can see that people are not eating that much plant-based proteins. And when I say plant-based proteins, I'm thinking of things like chickpeas and lentils and beans and peas, for example. And we asked all of our intervention participants to consume at least 1 serving of those, and then again also to have some nuts and seeds in a given day, because again that was a big element of the planetary health diet. With dairy, we reduced it to 2 servings instead of 3. And so this was essentially our My Planet intervention diet. So for the My Planet study, it was a randomized control trial. We recruited 350 participants across 3 different research centres, so UCD, UCC, and Queen's University in Belfast. Our participants came in and they were randomized either to personalised dietary advice. This is again something I've jumped over in the interest of time, based on the existing healthy eating guidelines, that being our control group, or personalised healthy eating advice based on our newly developed My Planet intervention diet, with the big changes there being with how we recommend meat servings, particularly, and specifically 1 serving of plant-based protein per day. We brought them in, we did dietary intake measurements, we took blood samples to look at nutrient status and to look at health markers, and they followed their advice for 12 weeks. They came back and repeated all of those measurements again. Our primary outcome measure in this case was our diet-related greenhouse gas emissions, so essentially calculating could we shift diet-related greenhouse gas emissions by giving this dietary advice alone. And you'll see from this slide that we did, and we did it quite effectively. So if you look at the left-hand side, on the next 2 slides, the control group health eating guidelines is in blue, and the intervention group, those following the My Planet diet, are in green, the lighter colour being the baseline, the darker colour being the end point. So you can see that both the control and intervention reduced their diet-related greenhouse gas emissions, but much more so in the intervention group relative to the control. So the intervention dropped by 33%, whereas the control dropped by 12%. Remembering back to that kind of early slide where we knew if people started to follow the health eating guidelines, they would be following a more sustainable diet. So we weren't surprised by that change in greenhouse gas emissions for the control diet. Thankfully, we saw an improvement in the overall healthiness of their diet in both groups, to the same extent actually, and we used the Healthy Eating Index as a measure of kind of total diet quality. We do start to see some differences, though, when we look at individual nutrients. So overall, we actually saw an improvement in their diet. Their fiber intake increased. So top left-hand corner, you can see the intervention fiber increased more so than the control group. We did see a decrease in protein, and this we kind of expected to happen. Thankfully, Nobody was below the recommendation of 0.8 grams per kilogram body weight, so it didn't actually impact where they were. And again, we kind of knew this. We knew that people were over-consuming the amount of protein that they were kind of recommended to eat. The concern, though, is on the micronutrient side. And as you can see here, we did see a drop in calcium and B12 relative to baseline for our intervention group, which was greater, obviously, than the control group. And we saw that for some other critical nutrients like riboflavin and zinc as well. We did see some improvements in some micronutrients, so vitamin C and folate, for example, all went up in response to the intervention diet. But the concern being that some were not meeting recommendations for those calcium, zinc, riboflavin, and B12, and that the impact was seen more so for females than for males in this. So in the long term, micronutrient intake would be a concern. The last point I'm going to make in relation to the My Planet diet relates to adherence to specific recommendations, okay? And so what we found was actually the reduction in meat that people were asked to follow was the most adhered to recommendation. And this was somewhat surprising because we thought that it was going to be difficult for people to change that. However, what was actually difficult was in the intervention group where we were recommending the increase in plant-based proteins, people found that most challenging. So adherence to the plant-based protein recommendation was the least adhered to food group. You'll see, interestingly, for the control group, the dairy food group was the least adhered to, in that people found it really challenging to increase to 3 servings per day from their typical. I'm just checking my time. So adherence is difficult, not so much for the food group where they were being asked to reduce it, but for the food group where they're being asked to introduce something new to their diet. That's where they found it challenging. And the kind of crux of the matter was behavior change. Changing behaviors to introduce a new food was much more challenging than changing a behavior by reducing a food. And so that is where we have gone to in the next round of this study, which is the PlanEat study, which is a European project. Within that, we have 9 living labs. Our living lab in Dublin, so the living lab that I'm leading, is actually young adults attending university, which is very nice because it means that you have a catchment of 33,000 students around you to recruit to it. Very quickly jump through what we did here, and I'm showing pilot results from our intervention study that's actually ongoing now at the minute. So as well as personalizing dietary advice in this, what we are doing is personalizing behavior change supports. And so this is actually the first time that we've done anything like this in my kind of 15 years in this area of research. We've never actually personalized based on what kind of the barriers to dietary behavior change are. And so it's pretty interesting. So in this pilot, we did a survey initially to figure out what students were identifying as their biggest barriers to dietary change. And using this information, we designed our study so that the intervention group were getting personalized behavior change supports. The control group were being asked to change their diet in the same way. In this study, we were asking them to increase their plant-based protein intake, but they didn't get the behavior change support. So to give you an example of behavior change supports, if somebody identified lack of convenience as their biggest barrier, they were given the foods. If somebody identified lack of skills, so lack of cooking skills, we did actually cooking demonstrations with them and gave them recipes. If somebody identified lack of habit, we did goal setting with them and helped them through the kind of stages of change. You can see from this slide that our intervention group, which is in green here, increased much more than our control group. We did see an increase in legume intake in our control group, but to a greater extent in our intervention group, who were the ones that were getting the behavior change support. So very positive. The difficulty now will be to see whether or not we can do that on a greater scale. So that was one food group recommendation. We're now doing an intervention where we have four 4 different food groups that they're getting recommendations for, and each of the 4 has a different barrier to dietary behaviour change. So they're getting personalised dietary advice on 4 food groups, as well as behaviour change supports in 4 different ways, potentially. So I suppose overall, what is the take-home message? First of all, healthy eating guidelines in Ireland are somewhat similar to sustainable healthy diets, but our difficulty is we're not following them. We can change diets with dietary advice alone to be more sustainable, but behaviour change is a huge barrier. And so going forward, what we really need to do is to look at not only designing diets that are more sustainable, but doing it in a way that we can support that dietary behaviour change. That's it from me. Thank you. And apologies, I know it's over there.
Do you want to take a seat here?
Yeah.
Thank you, Afric. That was fascinating. And as a haematologist, I have lots of thoughts coming into my head about those micronutrients, and I probably could do with some of those interventions myself to improve my own diet. But in the interest of time, we're going to save all the questions for the end. So we're moving on to haematology, which is obviously my own personal area. And Dr. Janis Krajcek from Galway is going to present on what's happening in haematology.
Thank you very much for the opportunity to talk today. I think hematology is a very thriving environment and discipline to develop interest and to go into. Myself, I'm practicing clinical and academic hematologist since 2012 in Galway, and I have also a pleasure to work in the clinical trials. So today I'm not going to talk about what we have achieved, what we are doing, but I will share with you some thoughts where we are going and what's the future ahead of our patients, us as a clinicians, but also clinical trial professionals. So I always start with the kind of comment that hematology is in the front line of development of cancer therapies and cancer approaches. Just to illustrate this, first stem cell transplant that is used in a lot of indications was developed by hematologists. First targeted treatment, imatinib, was developed in the late 90s, and subsequently targeted treatments are part of almost all regimens across different cancers. Immunotherapy, rituximab, also was pioneered by the hematologist. But now we are moving to the new era. We are moving to the new era of immune cell therapy engagers, T cell therapies, CAR T cells, and chemo-free regimens. So let's see what we have. I mentioned the priority, and what you see in the hematology at the moment is chemo-free regimens that we can use in more and more indications and more patients. Currently, we are thinking about developing treatments that will be completely chemo-free from a number of indications that I will illustrate later. Bispecific antibodies are becoming a routine in our treatments, and there is still a lot to achieve in the futures, and new generation CAR Ts are coming rapidly through the ranks. So I will demonstrate those theses with 3 different examples. Recently published paradigm trial of azacitidine and venetoclax in patients with newly diagnosed acute myeloid leukemia. As you know, about 150 patients are diagnosed every year in Ireland with acute myeloid leukemia, and about half of them are fit enough to receive treatment with curative intent. The standard of care currently and up until now was chemotherapy based with the standard 3+7 regimen with high dose of itracycline and cytarabine. This paradigm trial was randomizing patients between standard chemotherapy and chemotherapy-free regimen, azacitidine and venetoclax. What is important and what is shown that actually chemo-free regimen is showing better survival, better progression-free survival, and less toxicity. So this is the first time that I think our field, our discipline will be moving towards offering patients chemo-free regimen with previously very aggressive, very high-risk malignancy. The next thing that is very rapidly being developed in hematology are bispecific antibodies. everyone knows about monospecific antibodies that are very well established in clinical practice across different indications. Bispecific antibodies are different. They have two specificities, one specificity against an antigen on the surface of malignant cell, if it is myeloma or diffuse large or lymphoma or other cell, and another specificity is against T cell antigen CD3 on the T cells. So what bispecific antibodies do, they bring in physical contact the malignant cell, the target cell, and patient-own T cells, resulting in rapid destruction of the target cells of the malignancy with very high clinical efficacy and very good clinical safety profile. Just to illustrate where we are with the bispecific antibodies and chemo-free regimen, TEC-DARA trial that was recently published is using daratumumab, which is a monospecific antibody used in multiple myeloma, were established, and teclistamab, which is a bispecific antibody. This trial was performed in patients, was offered to the patients in first to the third line of treatment with multiple myeloma. Remarkable outcomes: progression-free survival, 83% reduction of the progression risk in patients receiving the immunotherapy bispecific only, significant difference in overall survival, but what is remarkable also that minimal residual disease negativity is more than 90% in the treatment arm. The patients who responded, they were progression-free in more than 3 years afterwards. So this is another example of treatment of chemotherapy-free regimen that offers excellent outcomes. And the third example, next generation of CAR-Ts. We probably all are very familiar in the CAR-Ts in the current clinical indications, let's say lots of indications in established B-cell lymphoma treatments, diffuse large B-cell lymphoma, follicular lymphoma, other lymphomas quickly coming, and obviously multiple myeloma. CAR-T is a very complex treatment, requires a lot of logistics and a lot of multidisciplinary input. Just to mention that patient needs to be identified and collected in the local treating hospital. Then material needs to be apheresed and sent to the manufacturing center, usually in continental Europe. For us, it's usually Amsterdam, Germany, Spain. Few products are still being shifted to US. Afterwards, material needs to be modified, manufactured. It's sent back to the treatment hospital. When patient is getting bridge chemotherapy, is getting lymphodepletion, and then it's being treated. Probably this is one of the most complex treatment regimens, treatment protocols in medical oncology and hematology at the moment. However, this is the technology of the past. Current approvals are using the standard CAR-Ts, and the field is rapidly moving to the future. So what's the future in the CAR-Ts? One of the very interesting advancements is the development of in vivo CAR-Ts. What it means for the patient, it means that patient can be treated on-site in the treatment hospital without need for apheresis, without the need of transferring his material to the manufacturing site, without the need for bridging chemotherapy. So the time of the treatment can be rapidly, quickly shortened. So phase 1 of in vivo CAR-Ts were published just in December. For a limited number of patients with relapse or refractory multiple myeloma were treated with KLN 1010, which is the in vitro CAR-T protocol. The patients received vector lentivirus intravenously on the day of the treatment. It was single infusion, and all of the patients treated has achieved 100% MRD negativity after the infusion. Interestingly, there was no standard expected complications of CAR-T treatment, so there was no cytokine release syndrome, there was no neurotoxicity observed, there was no other safety signal. So we are at the break of revolution when we'll be in position to treat patients immediately with off-the-shelf material on site in the treating hospital with a new genetic treatment. So this is I really believe that this is a space to look for, and what it means for us, what it means for clinical trials performed in Ireland. Obviously, it creates a massive opportunities because we are dealing with treatment that offer high response rates, deep remissions, and long-term overall survivals. Patients can have access to the fixed duration treatments as opposed to long-term treatments, and new combinations will require new trials and new treatment approaches. However, adopting those clinical trials here in Ireland is related to some challenges. So some of those treatments will be long-term, like combination of immunotherapies administered until progression. Some of the trials will require very complex logistics, especially the CAR-T trial with shipment of material overseas. Some of the trials will be associated with very specific toxicity profile that is not common and not easily recognized in other routine protocols. So let's mention cytokine release syndrome, for example. And also there will be a challenge because those patients will require rapid treatment and rapid admission to the hospital, which will put further strain on our already under-resourced clinical service. So I think this is a very interesting time for us, and I would encourage everyone, especially everyone who is considering career in clinical trials, to develop interest in those modern technologies, modern treatments. So thank you very much, and I'm happy to take questions later.
Thanks very much, Janusz. And again, we might reserve the questions to the end of the session. Next up for medical oncology, the talk we've all been waiting for, Dr. Emily Harold.
Good afternoon. I'd like to start by thanking the organisers for asking me to talk. And hopefully by the end of the talk, you'll feel that there's at least a little bit of innovation coming down the track for oncology, similarly to haematology. And I think within this kind of broad brief, what I'll try and do in the time that I have is talk about what I think are the main themes that we're starting to see across oncology. And there will definitely be a GI focus and a little bit of genetics in my talk, but I think these are themes that we're starting to see increasingly applied across tumours, regardless of tumour site. So I'm going to talk a little bit about perioperative sequencing of treatment and intensification of perioperative treatment. And this is really important because we think about this as the potentially curative space. I'm going to talk about the natural segue then to non-operative management of early stage disease. I'm going to talk about early biomarker-directed therapy in metastatic disease. I'm going to talk about ctDNA because I don't think it's possible to talk about innovations in oncology without at least covering its potential utility. I'm going to talk about a paper that was just published this month, which looked at a vaccine for cancer prevention in Lynch syndrome. And then I'm going to finish on one of, I think, the high points of 2025 with regard to the role of adjuvant exercise that has just been integrated in the ESMO guidelines this week in the treatment of adjuvant colorectal cancer patients. So the sort of poster child for perioperative sequencing strategies and the change in which we've managed them is when we think about early stage rectal cancers. Historically, we treated these patients with surgical interventions, and then the oncologist, came in afterwards. The radiation oncologist also was involved, and then we saw this paradigm shift where we moved neoadjuvant radiation, neoadjuvant chemoradiation all to the preoperative space, leaving challenges in the adjuvant setting post relatively large, quite morbid operations. And now really in 2025, what we've seen is this complete shift to total neoadjuvant therapy, whether that includes short course radiation or long course radiation, neoadjuvant chemotherapy, and neoadjuvant and indeed potentially definitive immunotherapy in a small biomarker-directed cohort, such that we're taking the surgeon out of the equation for a proportion of patients supported by both trial and real-world data. When we look to perioperative intensification of systemic therapy, and again, this is a little bit of a corollary to some of what we've done in rectal, but it's applicable across tumour sites. Prof Naidu talked about the keynote study looking at perioperative pembrolizumab. And then in 2025, we had the Checkmate 816 with Professor Ford's group looking at neoadjuvant immunotherapy and chemotherapy for resectable lung cancers. And again, then similarly in triple-negative breast cancers, we had the Keynote 522, which looked at neoadjuvant combination immunotherapy and chemotherapy, again in this potentially curative space, with potentially increased morbidity, but with really statistically significant and clinically significant changes in survival, event-free survival, and correlations with pathological complete response rate. And we can argue about whether all patients need this level of intensity and whether the duration of treatment is appropriate. But what we very clearly have is validation of preclinical work, which suggested that immunotherapy works best when the tumor remains in situ, almost like an in situ vaccination strategy. And then it finally came to GI with the Matterhorn study, which looked at locally advanced gastric and gastroesophageal junction tumors. And earlier last year, we had event-free survival data, and then finally we saw the overall survival data at ESMO, which looked at a statistically significant difference between groups that were treated with perioperative FLOT, which is a triplet regimen, and in addition, those patients received both preoperative and postoperative immunotherapy. Again, when you look at subgroups, some groups were less well represented. The magnitude of benefit, actually, if you look by gender, may not be as robust, but really this is a really significant step forward and a drug that we were fortunate enough to get access to for a period of time in Ireland relatively quickly after this data was made available. And again, in this potentially curative space, these incremental gains, increases in PAT-CR rates, and proven survival advantage, it's really important to consider accessing these drugs for our patients. But again, a little bit of inherent bias here in that these patients were fit for a triplet in addition to immunotherapy. And then here is what is now referred to as the Shalabi plot. So this is moving a preoperative therapy to a situation where a very specific biomarker-directed cohort have benefited from treatment directed towards that biomarker, which is relatively accessible with IHC in really every context when we're treating GI malignancies. And what Miriam Shalabi's group did in this window of opportunity in resectable colon cancers is again building on that idea of intensification of preoperative therapy. And these patients received only 2 cycles of immunotherapy. The first had a CTLA-4 inhibitor with a PD-1 inhibitor, and the second cycle was a PD-1 inhibitor alone. And what you see here is a major pathological response rate of 95% with a very brief period of exposure to immunotherapy, and a 68% pathological complete response rate, raising the question as to whether these patients required the surgery at all. And Caroline showed some lovely data about real-world experience in a setting of patients initially designated as unresectable, having really significant responses to variable durations of immunotherapy. Our English colleagues followed a similar paradigm looking at preoperative pembrolizumab for 3 cycles, again a short duration of exposure to immunotherapy with a really significant pathological complete response rate. And what's interesting here is that we do see these responses, whether this is Lynch-associated cancer or non-Lynch-associated cancer. But Shalabi's data actually suggested that there was a statistically significantly higher rate of PAT-CR rates in patients with Lynch syndrome-associated deficient MMR cancers. And then this study, again, in this context of preoperative intensification of therapy, potentially omitting surgical intervention, when it was published, there was a little bit of disbelief because, again, it's unprecedented that you would see a trial with a 100% response rate and all patients receiving the study drug not requiring a surgical intervention and not requiring radiation. And for this cohort, young patients, the avoidance of radiation, particularly pelvic radiation, is sometimes important from a fertility perspective. And really having access to 6 months of this dostarlimab, which is a PD-1 inhibitor, really was associated with relatively modest toxicity and a really profound response, which is made up as a composite of endoscopic and radiological assessments with some nice ctDNA correlates, which we'll cover a little bit later. So this really defines the error of definitive PD-1 inhibitor in deficient MMR rectal cancer and allowing for the omission of a surgical intervention. And then they went further in 2025 and they presented the non-rectal cohort, because I think from the perspective of morbidity and toxicity of the rectal cancer surgery, avoidance of surgery is a big patient preference. And when it can be done safely with a long duration of follow-up that now exceeds nearly 4 years for the rectal cohort, the question is, can we extrapolate and move this pre-operative intensification or definitive immunotherapy to other tumor types, which you can see represented here with urothelial, hepatobiliary, colon, gastric, small bowel, endometrial, and prostate cancers. And what's really important is that this is a clearly biomarker-defined cohort that is responding to an appropriately targeted treatment. And this is just represented differently. And in the sort of blue lines, what you can see is the rectal cohort with this really long duration of follow-up across the x-axis. And what's really important when you dig into this data with immunotherapy in this setting, that some of the patients, particularly in the rectal cohort, didn't meet the criteria for complete clinical response at 6 months, and some of them it took up to 9 months for them to be designated as a complete clinical response. But in this study, those patients were allowed to continue with close surveillance, and we have a patient similarly who did not reach a complete clinical response until 9 months after having stopped their immunotherapy after 6. And what's called out in the panel here with the complete clinical response is a potentially resectable biliary tumor, which again, we consider to be really critically a surgical disease when it's resectable. And this patient had 6 months of dostarlimab and has not required surgery with no evidence of disease. Again, thinking about the underlying mechanism of the IHC loss and what's driving that from a DNA repair pathway perspective is going to be important, because we do now sense that potentially the different DNA mutations may actually influence the sensitivity to immunotherapy. So there's a lot to think about in this study, but it's a really important study from a patient population perspective where potentially morbid surgeries can be avoided. So this is what precision oncology will probably look like in 2026. And I think for the first time in a long time, there's a lot of hope that our treatment paradigm is going to change, because our standard backbone of chemotherapy has not changed for quite a long time. And equally, we haven't seen the same kind of successes with precision oncology that are seen in lung cancer settings, where a single target can be targeted for often years at a time. We get much earlier emergence of resistance in the GI space in general, and we tend to need to combine therapies in order to see more durable responses. And that brings me on to this study, which I think was, again, one of the headlines of 2025. So this is for BRAF-mutated metastatic colon cancer, which has been traditionally associated with the worst prognosis across colorectal cancer. We've seen modest benefit of targeted therapy in this setting, in the second-line setting, and we know that these tumors respond less to conventional chemotherapy in the first-line setting. And when this was presented in January of 2025, what you can really clearly see here, even if you don't like looking at Kaplan-Meier curves, is that there's a really statistically significant and clinically meaningful difference between the interventional arm and the standard of care. And what this looks at is combining FOLFOX, the standard backbone, with encorafenib and an EGFR inhibitor to sort of bypass the mechanisms of resistance we know about to BRAF inhibition. And the median overall survival in this study rose to 30 months, which brings the survival in a traditionally very poorly prognostic cohort to comparable to BRAF wild-type tumors. Really unprecedented for a tumor type that we really thought we were running out of options for. And then just this month, we had data presented with regard to using FOLFIRI as a backbone, because obviously there isn't the same concern with regard to chemotherapy-induced peripheral neuropathy. And what we have seen over the space of 12 months is really the emergence of a new standard of care for a very poor prognostic cohort. And one of our interns has presented a poster today looking at a complete response in someone with very advanced BRAF-mutated metastatic colorectal cancer to this regimen with very acceptable and expected toxicities. And then I'm going to touch on ctDNA, because I think we've spent the last sort of 2 to 3 years talking about the promise of ctDNA, and we've been disappointed about the predictive benefit of ctDNA in a wide variety of contexts, despite the promise of using it to sort of tailor and personalize patient care. There have been limitations regarding the assays that we've used, particularly when they're not tumor-informed. There is definitely hope for building out MRD strategies and targeting those different molecular mutations. But 3 presentations in 2025 have given sort of renewed hope that the technology has evolved with a level of sensitivity that may actually improve the predictive capabilities of ctDNA. So in the Galaxy study, this is a cohort that we probably don't see a lot of in Ireland. So this was early stage rectal cancers that were resected. And in the MRD window, there was a very clear separation of prognosis in ctDNA positive patients and ctDNA negative patients. And the durability of that ctDNA MRD detection, if you were negative at 3 months and at 6 months, your prognosis was better. If you were ctDNA positive and you cleared the ctDNA, you had a better prognosis than those who remained ctDNA positive throughout. But interestingly, this study also demonstrated that in that ctDNA positive cohort, those were the patients who most benefited statistically from the addition of adjuvant chemotherapy, giving a hope that this personalization of chemotherapy may actually become, I suppose, within our grasp over the next couple of years as the sensitivity of these panels increase. And then going back to Dr. Sursek's study, one of the other criticisms of ctDNA is that we can't use it in early stage disease because the sensitivity isn't adequate. So that study, if you'll remember, was all deficient or rectal cancers. They were early stage, but the detection of ctDNA at baseline, this is using a tissue-informed assay, was 100%. And what we can really clearly see is that the dynamic changes in the ctDNA were actually predictive of the response. Now, whether everybody needed to get 6 months of immunotherapy, again, remains unclear, but this is a really important proof of concept that in early stage disease, an adequately sensitive ctDNA assay can actually be very helpful with regard to assessing complete responses. And this is one of the challenges of applying this data in the real world. We don't use PETs in this context, which were used in the study, and additionally, they had this lovely correlative work to again reassure them about these complete clinical responses. And then finally, going back to Breakwater study, which the Regis in my clinic hear about a lot. Again, in this study, they looked at ctDNA correlates with outcomes. And if you had an undetectable BRAF V600E ctDNA at cycle 2, day 15, this correlated with a longer overall survival. And we also got information biologically as to why these patients were doing better, because they had a much slower emergence of the resistant mutations that we associated with resistance to targeted BRAF inhibition. So this is a really important study, and again, as I've said, really does establish a different standard of care for this poor prognostic group. And then I just want to touch on this study because it was just presented in Nature this month. So the NewsCom 209 study looked at a vaccine for patients with Lynch syndrome who had, for the most part, not had a cancer diagnosis. A very small proportion were actually survivors, and a very small proportion had actually previously had exposure to immunotherapy. But the vaccine has been developed based on this idea that in deficient MMR tumors, you'll get this recurrent frameshift mutation pattern. And the 209 references the most frequently recurring frameshift mutations. So the idea was in these patients, after they were primed, they received this vaccine, and then they would look at both immunological correlates, i.e. as response to the vaccine, and then they would also look at sort of correlation with subsequent cancer risk, which hasn't been read out yet, and also subsequent adenoma risk. And what you can see represented on the right-hand side of the slide is that across the cohort, everybody had some degree of reaction to the vaccine. It's interesting that some of the lower responders actually had had a prior cancer, and one of them at least had had prior exposure to immunotherapy. And then what's represented here on the left-hand side of the slide is that these patients, if they had had a high response to the vaccine, really didn't have a lot of adenomas. So again, a hint that this is a genetically defined cohort that actually might benefit from an intervention to reduce the subsequent risk of cancer, or potentially at least reduce the risk of polyps leading to colorectal cancer. Again, really exciting data, and this is just one of many studies that are looking at a variety of different approaches in these patients. And then I'm going to finish on the challenge study because I do think that this is a call to action for all of us. And I know in our WhatsApp we were talking about this during the week. If this was a drug, we would be fighting to get access to it in our clinic, and a pharmaceutical company would be very wealthy at this point. Because essentially in this study, which references supported behavioral change, similar to what Prof O'Sullivan has talked about with regard to the dietary interventions, in this study patients were allocated a dedicated exercise consultant. The follow-up in the first 6 months was very intensive and predominantly in person. In the second 12 months after being included in the study, it could be virtual, and these patients were supported with exercise after they had finished their chemotherapy for early stage colon cancers for up to 3 years with this supported behavioral change. And essentially, for every 14 people that were treated with this protocol, exercise prevented one person from dying, either from recurrence of cancer, a subsequent cancer, or another reason. And we saw similarly encouraging data with regard to progression-free survival. I know some of the oncologists here, since my training, have been prescribing exercise to their patients, but this is a really clear evidence of the benefit of adjuvant exercise that we should be prescribing in our clinic, and is now part of the ESMO guidelines for early onset rectal or early onset colon cancers that have completed their adjuvant therapy. And that's what the ESMO guidelines looks like just this week with regard to this concomitant participation in a structured exercise program. So that is a whistle-stop tour through some of the innovation in oncology over the last sort of 14 months. Thanks for listening.
I agree. I think medical oncology is up there with haematology for innovation, and I'm really excited, particularly about your exercise piece, because we're actually about to start a bit of a study on that in the matter that you will remember we both were working on before you left. But without any further delay, I'm going to introduce Professor Sinead Brennan from St. Luke's Radiation Oncology and St. James's Hospital, who I meet regularly online, but very rarely meet in person. So I'm delighted to introduce her today to give us her update on radiation oncology.
Thank you. I'll just wait for the slides to load there. I've taken a slightly different track today. It's more of an Irish focus on what's happening in Irish radiation oncology, because I wanted to try and highlight opportunities for trainees, both current and future future opportunities for our fellows and trainees to change practice in treatment for our patients. So the title is Irish Designed Investigator-Initiated Trials in Radiation Oncology. So IITs, as we call them, are led by independent researchers. They answer specific scientific questions that often arise in day-to-day practice. The concept often arises just in clinic or at an MDT, and it's triggered by patient need, a situation where we're not really sure what we should do, so let's design a trial to try and answer the question. And generally, the local team are involved, or the trials unit is involved in the design and the conduct and the management of the trial, rather than having a pharmaceutical or a medical device company. So just a brief mention on IROG. So this is a national radiotherapy clinical trials group which unites all of the radiotherapy departments around the country. We're funded by the HRB. But the real strength of IROG is that it brings together a critical mass of expertise. So it brings together all radiation oncology researchers in the country. We've got an active PPI group, and it's a really excellent platform for national and international collaboration, as hopefully you'll see. We recently launched a website which signposts our trials to both our patients and to our fellow researchers, so that's irog.com. And when we started IROG, we had a plan on how to increase accruals to trials, and that was establishing our group, involving more consultants and other researchers as principal investigators, involving patients in design and prioritization of trials. We wanted to work really strongly with our partners in CTI on startup efficiency and expand our national and international collaboration. And what we have achieved is, before IROG, we had about 12 consultants who were actively involved as PIs of trials. But since IROG, we've doubled the number of active PIs. We now have 29 consultants who are actively involved in research. I must get the percentage of our total numbers, but I imagine it's probably close to 50% of our consultants being active PIs. We have a very strong PPI group, and they were involved in contributing to the website design. And so hopefully it's a very patient-friendly access point for patients to find out what clinical trials are, how to get involved with them, and hopefully take some of the fear of clinical trials away for patients. So as a result of all of this, in 2025, we had 19 trials open to accrual. So that's not, active trials or trials that are in follow-up. They are actually open to active accrual. We had 299 patients on trial around the country on radiotherapy trials. This was a huge increase. So we had started off at a baseline of 72 patients per year. We tripled the number in year 3 and quadrupled the number last year. But what's also interesting is that half of the patients were on IITs, so Irish designed trials, and 72% of our trials were interventional trials. So radiation oncology as a community have a very strong track record in designing our own trials. Some of the highest recruiting trials over the last 20 years have been trials that have been designed here. And we can attribute to the success of that program is because the concepts often came from our clinics. They were addressing an area of unmet need, as I was explaining, and they're always designed with our patient population in mind, so that they're a good fit. Within the IROG HRB grant, we have a work package dedicated to IITs. And this diagram just shows that when IROG was established, we only had one IIT open at the time. It was open in St. Luke's and in Beacon. That was the source trial. But since then, for this year, we now have up to 9 trials, either open or very close to opening, and they're opening all around the country and in the north as well. So I think a lot of the success is attributed to our St. Luke's Institute of Cancer Research multidisciplinary fellowship program, and that's probably been ongoing for close to 20 years, kind of unofficially and then more officially labelled. They were registrars and then they were designated as fellows. I spent some time at the CTRU. Lots of the consultants around the country had opportunities to spend time within the St. Luke's clinical trials unit and to perform extra research. So our current fellow in radiation oncology is Jill Nicholson. She's currently doing an MD, and the next fellow that's hopefully coming to us will be doing a PhD as part of this of their research fellowship at St. Luke's. So just to mention some of the IITs that we have, the Source Lung trial is led by John Armstrong, but it was designed initially by Ronan McDermott, who was a Slicker Fellow at the time, and unfortunately I don't have Ronan's picture here, but I don't think he's here, so that's okay, he can't give out to me. But this is a really great trial because it looks at high-risk central lung cancer tumours, and these patients would otherwise be receiving palliative treatment, but they can have radical stereotactic treatment through a carefully designed trial. This trial is open in Luxon and Beacon and is hopefully going to open in Belfast in the next few weeks, and we're hoping to roll this into a phase 3 trial, which the next Slicker Fellow in the next year should hopefully take on. So a nice kind of circle of continuity there between one fellow starting and then another fellow taking that project on to the next level or the next life cycle. The Optimise trial is a trial, again, lung stereo, but peripheral stereo this time, peripheral lung cancer, looking at the safety of giving 3 fractions rather than 5 fractions of stereotactic treatment. There's a huge, I suppose, focus in Cancer Trials Ireland, led by Seamus, on cost effectiveness and value of clinical trials. So if we can do these treatments in shorter treatment times, that's better for the patient. They can get back to work, back to their families, especially if they have to travel for treatment. But also, it's more cost effective for our departments locally. So cancer trials don't always cost money, and we're not always difficult people. Sometimes we're actually bringing contributions back to our departments as well. The dose escalation IMRT pancreas trial is led by Jerry McVeigh and Maeve Keys. It's looking to try and safely increase the dose of radiotherapy in pancreas cancer. Another trial which was designed by Schaefer O'Sullivan, who was a Slicker Fellow at the time, and also supervised in a nice mentorship model by Claire Fall, is the Spine Sabre trial. So for patients with spinal metastases, trying to safely, without compromising vertebral structure and reducing vertebral toxicity, but increasing the dose to these spinal mets to improve local control, which is hugely valuable in patients with spinal metastases, obviously trying to maintain their function and quality of life by increasing local control of spinal metastases. So the INSPIRE trial then is a pan-island trial of high quality and low toxicity prostate stereotactic treatment. Some of the earlier trials of prostate Sabre haven't really taken off because there was a concern based on international literature that perhaps the toxicity wasn't as low as we'd like it to be. So this is a really fantastic trial which has involved so many people all around the country. Brian O'Neill, Sunil and Paul Kelly have been involved, but a huge other group of people as well involved in designing this trial of physicists and RTs, trying to say what would be the gold standard, the ideal high quality radiotherapy to reduce toxicity for prostate Sabre. So that hopefully will open in the next few months and open north and south also. The OPEN trial then is a trial that came from an unmet need, as many of these trials do. We know that mask anxiety can affect up to 26%, probably more, of head and neck cancer patients. We were aware that these new open face masks existed. Rather than just bringing them in, we wanted to test them in the context of a randomized controlled trial. Same as we should do for drugs, for all new technology and any new changes in surgical management. We should always test changes in the context of a randomized controlled trial. So patients were randomized to one of these 3 arms. The trial accrued 230 patients in 16 months. It was a trial coordinator, radiotherapy, nurse-led consent process, and that experience has just been accepted for ESTRO this year, which we're delighted to see. It's also a green trial, and really successful in our departments. We had the safety check of 3D surface-guided radiotherapy, which is able to track patient motion with sub-millimeter accuracy. And this trial went from initial concept to presentation of results in 2 years. So, you know, not every trial needs to take 10 years to happen. Obviously, this was a certain trial design that allowed it to be done quickly, but sometimes you have to get things done quickly in order to actually have real impact. So the primary endpoints are that, and sorry you can't see these slides, I think the format has changed on me, similar to some of the earlier speakers, but the primary endpoint was that the open masks were just as accurate as the closed masks. There was no more increase in patient motion or difficulty with setting patients up for treatment. In fact, the closed masks were a little bit worse than the open masks, possibly because patients just weren't as comfortable, and therefore the setup from a day-to-day variation possibility was worse. From a patient experience point of view, obviously, as we might expect, they were more comfortable. Patients had lower GQ-12 anxiety scores and better overall experience. So very, very simple trial, but it was very impactful. It's been received very well internationally. We were invited to present a late-breaking abstract at ESTRO. It has gone out as Best of ESTRO. We've been shortlisted as finalist for a HSE Bright Spark Award, and it was featured at the Breakthrough Cancer exhibition on Stephen's Green during the summer. So on the back of the success of the open trial, we proposed a low interventional trial model to CTI, who've been working with us on this. So the idea is to fast track, you know, lower interventional studies for low-risk studies through the startup process. And we have 3 studies ongoing at the moment. The details aren't showing there, but the DETECT trial is led by one of our trainees, Jennifer Trustle, in Galway. She's not a fellow, she's a senior trainee under the mentorship of John Gaffney, and it's looking at increased CT surveillance to detect oligometastatic disease, which then could potentially be treated radically. So rather than waiting for patients to become symptomatic from the distant mets when it's too late and they have to go on perhaps prolonged courses of expensive immunotherapy and chemotherapy, if we can identify it earlier, we could treat them with stereotactic treatment. Orla McCardle has designed a trial of a treatment to prevent severe radiation dermatitis, and Aisling Glynn has designed a patient-empowered follow-up trial with strong patient leadership in that to try and empower patients through education and I suppose supports to direct their own follow-up rather than coming every 3 months and the anxiety that's associated with that. Oh, there are the details there. So then Aisling Barry in Cork is establishing a registry for patients who are receiving radiotherapy in Ireland. The data collection focused on PROMs, which is supported by a connected health platform called Zamplo. And we want to shed the light on the patient experience of radiotherapy in Ireland, a number of cohorts, and the potential to link with big data from a radiotherapy planning point of view, and also opportunities for translational research at the Michael Moriarty Lab in St. Luke's, and also through the Atron group, which is led by Jerry Hanna. So in conclusion then, hopefully I've given you an idea of what the magic recipe is, or how to establish a successful IIT program. Obviously you need ideas from enthusiastic PIs. Everybody has ideas. Everybody in the room here has an idea on a daily basis as to what we could do better for our patients. Mentorship is key. Hopefully I've shown you that today. From my perspective, I would think radiation oncology is very strong on mentorship. We'd obviously have to ask our trainees to get their side of things. But in general, we're a very tight-knit close community. So I think through the Slicker Fellowship especially, there's been great opportunities for fellows to work very, very closely with more senior researchers and to learn skills that way. Obviously, safety and quality is hugely important, and we were really proud to have launched our IROG National Radiotherapy QA program. Funding, as we all know, money makes the world go round, but what's interesting about our IIT program is that outside of our current existing infrastructure, which is, our trials unit and our HRB IROG infrastructure, none of the trials that I've mentioned actually were set up with additional funding. So we didn't say we can't do anything because we've no money, and until we get money, we can't do something. We try and find ways, working with our clinical departments, to try and get these projects over the line. So sometimes, we're not so lucky to have lots of pharma companies knocking down our doors trying to give us money to run trials. We have to be a little bit more inventive in radiation oncology. We're very appreciative to Cancer Trials Ireland, who sponsor all of our trials, and obviously very indebted to our patients and our PPI group. I think every IIT probably comes from us being in a room with a patient who we just really want to do more for and don't know how. So just to finish up by saying there's a trial in everybody. We start off, if you have an idea in a clinic and you develop out the concept in your head very quickly, a few small steps in between, you have a clinical trial. So hopefully that gives people some energy.
Thanks very much, Professor Brennan. Next up, representing surgery, is Dr. Jessie Elliott.
Okay, let me see, can I get this going? Yes. So thank you very much for the invitation to speak here today. And apart from one or two areas where I might overlap a little bit with Emily, I'm going to try and keep this a little bit different and focus on surgery. So I suppose I'm coming from a background being an upper GI surgeon. And so what I want to do is cover some kind of themes that are being explored in surgery at the moment. From the perspective of upper GI surgery, but they have relevance across multiple different specialties. So hopefully people will find this interesting, even though it's a little bit different than what we've talked about so far. These are my disclosures. So the themes that I think are very kind of hot and happening in surgery right now are, first of all, perioperative care, prehabilitation, and enhanced recovery after surgery, or ERAS. There's also a lot of research going on about different types of operative approach. So what is the best way of resecting a tumor and doing a lymph node dissection? I'll talk about that in a little bit of detail. There's a lot of research going on about different types of surgical access and new technologies, in particular the role of robotic surgery. And there's been a lot of work about kind of how we can best implement these new technologies. And as Professor Brennan has mentioned, for bringing in a new technology, we have to do that in the context of a clinical trial to ensure that we're doing it safely. And this is where SQI, which we use all the time, SQA, it should say, surgical quality assurance, comes into these trials. So there's also a lot of work going on in upper GI surgery, in particular in extended indications for surgery. And this has been something that has probably been later in upper GI than it has in, say, colorectal cancer. But I'll mention a few kind of active trials in that area. And then similarly, kind of lagging a little behind, probably because of numbers, our colleagues in lower GI cancer, we're starting to see a bit of work on rationalization of treatments and how can we achieve organ preservation for patients with upper GI tumors. And last but not least, my kind of pet area is on survivorship and post-treatment surveillance, and I'll just mention an active trial that we have at the moment. So when we talk about perioperative care, prehabilitation, enhanced recovery, this is something I really want to get across to everybody here in this room, because it begins on the very first meeting we have with the patient. And Michael Kelly talks a little bit about the marginal gains theory, and this wouldn't be a surgical talk if I didn't have a sports slide in it. So this is David Brailsford, who was the kind of head coach of the Sky cycling team. And he used this marginal gains theory approach of trying to get 1% here, 1% there to try and improve outcomes. And I think a very similar approach works well in complex surgical patients. So the minute we see these patients in the clinic who may be a candidate for surgical resection, for example, I'm looking at their nutrition screen, I'm looking at their iron studies, I'm trying to get their vitamin D levels up, I'm getting them into prehabilitation to see our physiotherapist. So it's this whole patient approach to try and optimize the patient as much as we can to try and achieve those small incremental gains that together add up in the long term to better oncologic outcomes and hopefully better survivorship outcomes as well. And there's been a bunch of different trials. I don't have time to go through them all in detail, but a bunch of different really good Irish trials in this area recently. So there was the PREPARE trial, which looked at preoperative inspiratory muscle training. There was RESTORE, which was rehabilitation after major upper GI surgery. PRE-HIT, which was high-intensity interval training for patients who were undergoing major thoracic surgery, so esophagectomy or lung resection. And then we're currently developing a trial called IRONIC, which is looking at different ways of managing anemia in patients with GI cancers at presentation. And we're working on that with the UK-Ireland OG Cancer Research Group. And this is a little overlap with Emily's talk. This is a huge practice-changing trial in GI cancers, the Challenge trial, which, as Emily mentioned, showed that a structured exercise-based behavioral intervention improves not just the amount of exercise patients are doing, but also overall survival and long-term oncological outcomes after curative intent treatment for colorectal cancer. And I think this really sets the bar for kind of supportive care trials going forward. We've done a lot of trials in prehabilitation, rehabilitation, and supportive care interventions using surrogate endpoints. And what this trial shows is that it's actually possible to look at major hard endpoints like overall survival. And I think this is what we need to aim for going forward. And obviously this requires a lot of collaboration and much larger numbers of patients on trial. But this is how we get our supportive care interventions into the ESMO guidelines. So a little bit around operative approaches, and this is a trial that we have open in the Trinity St. James Cancer Institute at the moment. So there's very few trials have actually effectively looked at which way of doing different surgical operations is best in terms of oncological outcomes for patients with esophagogastric cancers. So the CARDIA trial is one example of this. It's led by Christiane Bruns and Richard van Hillegersberg in Cologne and in Utrecht, where I previously worked. The trial is looking at this kind of difficult group of patients who have these type 2 gastroesophageal junction tumors, whereby it can be treated as either an esophageal tumor or a gastric tumor. And essentially, we're randomizing patients to having a transhiatal extended gastrectomy, taking out the entire stomach and the distal esophagus. And the lymph node dissection associated with that is shown here on the right-hand side, and that's the key kind of difference, I guess. Or to have a kind of two-stage esophagectomy, so a gastric conduit, and removal of about 2/3 of the esophagus. And you can see you get a much more of an intrathoracic lymph node dissection with this approach. So this is powered to detect a difference in overall survival and should be finished recruitment within the next year or so, and is going to be a big practice-changing trial in upper GI cancer surgery. On a similar note, we're hoping to shortly open the OMEGA trial, which is led by Suzanne Gisberts in Amsterdam. And this is looking at a very simple question of whether complete omentectomy, so resection of the omentum, actually improves oncological outcomes in patients with gastric cancer. Traditionally, we used to do not just a complete omentectomy, but also remove the entire bursa, which is this very thin structure that sits overlying the pancreas. But trials from the Far East have shown that in that context, it's not associated with any oncological benefit and may be associated with increased risk of complications. So we're trying to kind of rationalize the surgery that we're doing, make it less invasive, and hopefully maybe not all patients need to have a complete omentectomy. And it may have added nutritional and immunological benefits to be able to leave the omentum in situ. Looking at robotic surgery, this is obviously a big area of innovation, especially in GI surgery, but also in thoracic, head and neck, gynae, urology. So for anyone who hasn't been in a robotic operating theatre, this is sort of what it looks like. I couldn't find any pictures with a female robotic surgeon, unfortunately, on the internet, but here we are. So you always have a tableside surgeon who's usually a trained surgeon, an assistant who's helping swap instruments in and out on the robot. And then we have one or two console surgeons. So ideally you have two, one who's kind of lead surgeon and one who's training or learning. And this is how we can train our registrars in robotic surgery, so having a dual console system. So, the patients often, robotic surgery is a bit of a misnomer. The patients often think the robot's doing the operation. There's nothing autonomous about robotic surgery at the moment. So I call it's more like the surgeon is operating a remote-controlled car. So using these controls to control what the machine does. You can see we can achieve an esophagectomy, so this is a two-stage esophagectomy, using these 5 ports in the abdomen and these 5 ports in the chest. You can see that the quality of the view that we get, I'll see if I can show that again because I wasn't really paying attention. The quality of the view that we get is phenomenal. I'm sorry, it's not showing again. But it's really close up. We have 3D wristed instruments. You can see every tiny little blood vessel. So the amount of blood loss is much less in most robotic surgery trials. The operating time is usually a little bit longer. And there's a little bit of data coming out now on clinical efficacy. So in upper GI, we have shown that robotic surgery is associated with reduced post-op analgesic requirements, with improved early recovery, better cardiopulmonary outcomes. And what we don't know yet is long-term oncological outcomes as compared with a minimally invasive operation. So is robot better than standard laparoscopic surgery? And that's the focus of this Robot 2 trial, which has recently completed recruitment and has been led by Peter Grimminger in Mainz, who is an amazing robotic surgeon, and we'll be really looking forward to hearing the outcomes of that very shortly. So a little bit about the critical importance of quality assurance in trials that involve surgery. So this is, I picked this trial because it's very well known in upper GI. This is a Checkmate 577 trial. But you could pick any number of trials to show something similar. So importantly, the Checkmate 577 trial, for anyone who's not familiar, looked at adjuvant immunotherapy after a neoadjuvant chemoradiation and surgery for esophageal and junctional esophageal and junctional cancers. And the trial was run from the US, and it included, they screened over 1,000 patients at 170 sites over 37 months. The trial showed a benefit to immunotherapy. So that works out at about 2.1 patients per site per year having a major surgery, where we know there's a very significant volume outcome relationship. In the Checkmate 577, the control arm who didn't receive immunotherapy had a disease-free survival of just 11 months. And if you compare that to NeoAegis, which was run in Ireland and led by John Reynolds, the control arm who received chemoradiation, so the same treatment, had a disease-free survival of 24 months. So when we look at the Checkmate 577 trial, we have to say, was the quality of the surgery in that trial adequate to really test the added benefit of treatment intensification? And I think this often doesn't get assessed on review, and something that we need to look at. So in that particular trial, and credit to the authors for putting it together, it's a huge effort, but we don't know what the nodal yield was. It's not reported in the paper. We don't even know what proportion of patients had a transthoracic or a transhiatal operation or a D2 lymph node dissection. So there's very little included in that trial about the details of the surgery, and all of that makes it hard to generalize the results to our population. Another bit of work that's been done on this area by Suzanne Gisberts and the team in Amsterdam is looking at what lymph nodes surgeons are resecting as routine, and this is part of a bigger study called TIGER. And you can see that these percentages show the different percentage of surgeons taking each lymph node station in a patient with a distal esophageal adenocarcinoma. So there's massive differences in surgical practice, and this needs to be addressed. Another kind of big trial that we hope to open in the next couple of years is looking at placement of a catheter to deliver chemotherapy intraperitoneally for patients with peritoneal metastatic gastric cancer. And just as a little segue onto kind of extended indication surgery, which is another very hot area at the moment. So we've recently gone in for a big European grant, which I hope we'll be successful with, on the OMEC5 trial, which is an oligometastatic esophagogastric cancer trial, looking at treatment to the tumor and to the metastatic sites in these patients with limited metastatic disease. And there's a few other kind of active trials recently completed or ongoing in this area. Heading towards the end of the talk now. Looking at different other cancer areas like rectal cancer, we see that there's been great success in rectal cancer in achieving organ preservation in a large proportion of patients. And this is something we haven't yet achieved in upper GI cancers. And a lot of that is limited by a lack of really good quality trials in this area. So the SANO trial recently completed was a non-inferiority trial for surgery as needed after chemoradiation for esophageal cancer. A little bit controversial in our field, and ongoing is the NEEDS trial, which we're grateful is supported by Cancer Trials Ireland. And this is a squamous only trial. So very last kind of topic is the trial that we're leading at the moment, which is the SARONG-2 trial. And it's looking at intensive surveillance approaches after curative intent treatment for esophageal and gastric cancer. There are big differences in the proportion of patients who receive intensive surveillance around Europe at the moment. We've shown that in this ENSURE study previously. And we know that having intensive surveillance may improve outcomes for a proportion of patients who have early stage tumors or have favorable tumor biology. But it is associated with increased health anxiety and increased fear of cancer recurrence. So this is our SARONG-2 trial, which is currently ongoing. I'm pleased to say as of January 2026, we've recruited just over 170 patients across our European sites. And the trial is sponsored by Trinity and taking place in collaboration with the RCSI NSRSC, as well as Cancer Trials Ireland. So very grateful for the support from many of you in the room here for this trial. It includes a liquid biopsy kind of parallel translational study called Imagine, as well as a AI machine learning study looking at radiomics in the trial cohort, which we're really excited about. So none of this can be possible without collaboration across not just the Irish Upper GI Cancer Network, but also the European Upper GI Cancer Network. And the Dutch, where I worked previously, are big leaders in this area. And I think the message is that to deliver these big practice-changing trials in upper GI cancer, we need to come together to answer these big questions for our patients. And this is very much embedded in Dutch culture. So what's currently happening in surgery? Perioperative care, prehab, and ERAS are big features, but we need to look at hard endpoints, not just surrogate endpoints for these trials. We're looking at refinement of the operative approach, the implementation of robotics. Quality assurance in surgery is really important in any trials that include surgery. Extended indication surgery is currently being investigated, but is not standard of care as yet. And organ preservation is not yet ready for prime time in upper GI cancers, in my opinion. We're delighted to have the support of CTI for the SARONG-2 clinical trial. And I'd like to welcome any questions or comments from you guys during the discussion. Thank you.
Fascinating talk. I think we're just up for our last speaker, which is Professor Leonie Young from the RCSI, and we're moving a little bit from the clinical area to the more basic research translational area now, so look forward to that.
Thanks so much. So huge thanks, particularly to Seamus, for asking me to come to talk to you today a little bit about some of the more basic research elements that have fed into many of the clinical studies that we've just heard this morning. So I was just going to go briefly through some of the advances in structured biobanking and the difference that that can make to the type of clinical studies that we're undertaking. Some of the large-scale multi-omic studies, liquid biopsy, which you've heard extensively about already, radiomics and machine learning, and finally, the contributions of digital pathology and where that's taking us to. So a bit of a disclaimer, my research is in advanced breast cancer, so many of the studies that I'm going to share with you today have a breast cancer background. No matter what we do and no matter how we try to improve our precision medicine, without the background of the tissue to investigate, we cannot make any advances. And where we have had a freezer full of tissue over the past number of decades, this was rarely accompanied by consent forms or well-annotated clinical data, and therefore really was rendered rather useless. This has really all changed, and we have now started to collect material in a really consistent, regulated manner. And I just want to take you through some of the more famous biobanks in breast that are happening worldwide, just to give you a sense of the types of collections they have and the sense of the amount of work that goes into maintaining this. And if you are involved in surgery or have a chance to get involved in clinical trials, this type of work is invaluable, and it's a real feed forward. So probably the most famous breast cancer biobank is the one in Breast Cancer Now in the UK. It's over 11,000 patients currently, and it's set out over 4 different sites. So it's obviously many different types of samples, including fresh frozen, paraffin embedded, and blood samples. And it's given out a phenomenal 72,000 tissues to date, and that's made a huge difference in terms of our understanding of breast cancer biology. Another one is in Germany, and the reason that this is interesting is not just because of its size, but also because of its approach. It's an on-site pathologist who deals with all of the material as it's coming through, and then this is sent to a distant site for storage. A shameless plug for our own. This is our own breast cancer biobank. So myself and Arnie went to RCSI Beaumont in about 2012. We set this up, and with Verena, I can see in the audience, we set this up as a full clinical trial through Cancer Trials Ireland in 2016. To date, we've over 6,000 patients, both primary and metastatic, and the real focus for us was to have longitudinal samples. So where we saw our patient when they came at primary tumour, we then followed them every 6 months. So we had full annotation on all of their treatments and how they were doing. And then if they were unfortunate enough to relapse, whether it was the lung, the brain, the bone, we then took that tissue then. So this has allowed us to do longitudinal studies. And to date, we've the biggest collection worldwide of primary to brain metastatic tumours, and we have profiled them with WES to look at DNA mutations, RNA methylation, spatial annotations, and methylation of both the DNA and RNA. So we have a huge picture of how a patient changes from their primary to their metastatic disease. And this has given us, for the first time, a real appreciation of the amount of molecular subtype switching you can get from primary to metastasis, which has huge implications on their management. So just recently there in November, we got ISO accreditation for our biobank, and not just for the breast, but for all of the cancer biobanks within the Cancer Centre. And this is only the second cancer biobank worldwide to get accreditation. So it really ups the usefulness of these types of activities. If they're fully accredited, they are of interest not just academically, but also for industry. And the last one I just wanted to tell you about was sort of like the next generation of biobanking. So this is really looking at live biobanking that is enabling us to do real-time pharmacological studies. So this is an organoid biobank, and it's really thought that this activity will mean that in future new therapeutic combinations may not need to be tested in large animal studies, but this can now go from the bench to the bedside right back into the clinical trial situation. So yeah, thanks to Jessie and her innovations in robotics, getting tissue has now become a huge challenge. And to combat this, there's now what we call warm autopsy programs. So this was really spearheaded by Steffi Ustrich and Adrian Lee out of Pittsburgh, who'd one of the first of these programs. So basically, it does exactly what it said in the tin. When the patient is ready to pass, they get recruited onto this warm autopsy program, and then the autopsies take place. You can see that there's a large divergence between the amount of patients that they had consented and the amount of autopsies that performed, and that just gives you an indication of the difficulty in doing this type of work. I mean, relatives get cold feet, pathologists aren't available, these occur at all times of day and night, so it really is, it's a labour of love. But what has been really important is that we have really gained huge amount of knowledge on metastatic disease. And what we found was that metastatic sites were much more divergent than we previously had thought. And what was really fascinating from some of Steffi's work that she's reported is the huge amount of tumour burden that they found in the fat of patients, which has really previously been unrecognised. In Europe, there's the Up-to-Date Post-Mortem tissue donation program has also been hugely successful, and they've had 20 autopsies to date. And I'm saying that that program has been open over 3 years, so you can see what a huge burden of work it is. So what are we doing with all of this material once we get it? So we've all heard about omics and the importance of tracking gene mutations, but it's really trying to put that into context. So if we have, cell-free DNA or circulating tumor DNA, it doesn't really give us that much of an insight as to the heterogeneity of the cancer itself, whether it's primary or metastatic. And for that, we need to kind of go back and do a deep dive and try to learn as much as we can. So we do these multi-omic studies, and this is one of the better ones, Mosaic Multi-Omic Spatial Atlas. And it was just reported there in San Antonio in 2025. So it's a very large multi-omic spatial and single cell. So they did spatial transcriptomics. So that gives us near cell detail at a gene level. So you can map not only what's happening in your cancer cell, but also in the cells that are adjacent to it and how that influences. So if you take it that you're a breast cancer and you're communicating with cells in the breast, but if you go to the brain, then you're communicating with neural cells and astrocytes and all of the plethora that is there, and that really influences how you're going to behave as a tumor and how you're going to respond to therapy. So it's this spatial transcriptomics, single data, histology, bulk RNA-seq, and exome sequencing to look at these DNA mutations. So they have just released a small part of that, 60 patients, called Mosaic Window, and we wait with bated breath for further studies. This is looking really at a more clinically relevant one, I suppose, and looking at the relevance in terms of neoadjuvant treatment and what multi-omics can tell us in terms of predicting then long-term response to treatment and long-term survival. So I just put this one up. I know you've all heard of the Breast Atlas and the wonderful work by Walid Khalid out of Oxford. So this is, I suppose, the next stage in this. And this is the Breast Cancer Atlas. So this is literally giving us a map of what the breast cancer atlas, what the breast cancer should look like, and then we can start overlaying then things and changes that happen with treatment. So it's integrated over 600,000 cells from 138 patients. And again, it's multi-omic, integrating single-cell transcriptomics, immune profiling, to give us a sense of epithelial heterogeneity. And lastly, in this series, we're always looking at mutational changes in the DNA and even gene changes, but the protein is always what we're going to be targeting. So this is the last one. It's a proteomic transcriptomic integration study, and this was undertaken in estrogen receptor positive luminal type breast cancers. So although it's only just really been published, the data was really generated in 2025. So it's used proteomics and phosphoproteomics as well as transcriptomics, and this work identified novel metastatic markers as well as potential new subtypes with differential immune filtration. So we have heard a lot about liquid biopsies this morning and their importance. And we've always been doing liquid biopsies, and we've been doing, looking at germline mutations, BRCA1 and BRCA2. So the real advance is looking now at the circulating tumor DNA to see, can that tell us anything about the tumor itself? And the power of that is that it allows us to assess how a patient is doing longitudinally. So initially, we can look at circulating tumor and see, does that burden then associate with long-term outcomes? That's very important, but probably the real power is to be able to continue to monitor your patient in this non-invasive way to see how they're responding to it. So we are expanding the biology. We're not just looking at blood, but obviously CSF. The technologies are getting better, you have more accuracy and smaller volumes, and that there's many, many companies all competing with each other, telling you that the way that they're doing it is the best. But in sometimes they're right. So some of the companies are looking not only at alterations at a mutational level, but also giving an indication of the validity or the functionality of that mutation, because they're also applying ATAC-seq, which looks at an acetylation mark on the DNA, and that acetylation mark will tell you whether that gene then is likely to go on and be expressed or not, and therefore give you some sort of idea of functionality. We're using it obviously as companion diagnostics. I'm obviously obsessed with the estrogen receptor, so being able to track mutations in the estrogen receptor are really important to tell you how you're going to respond to aromatase inhibitors in particular. So integration into healthcare, these assays should not going forward be expensive. They're currently very expensive, but that this should be much cheaper than getting samples and tissue analysis. And then we're like, to be future ready, looking at minimal residual disease, relapse, and obviously immunotherapy guidance. So this is just a number of studies. I'm not really going to labor on these in the interest of you getting a sandwich at some stage. But Guardian Health is one of the bigger ones. It's a 40 multi-omic biopsy that was presented in San Antonio this year, and it combined genomic and epigenomic blood-based studies. This is the key of all of these studies. SERENA-6, it's an absolutely most beautiful study. So this was in patients with estrogen receptor positive disease, and they had standard of care. So I don't know, for those of you who may not be interested in breast cancer, but aromatase inhibitors have transformed treatment for estrogen receptor positive patients. But what we're now beginning to appreciate is that these treatments induced mutations in the estrogen receptor. And these mutations are in the ligand binding domain. And what they effectively mean is that those patients are going to relapse. And when they do relapse, we've no treatment for them. So this is a problem we have created ourselves. AI treatment induces these mutations. And if we cannot detect them, what we're going to end up doing is continuing to treat our patients with these AI therapies. And this is the genius of this plan, or this study. So what they have done is these patients have standard of care, and that they track them with their liquid biopsies, and there that they can see the emergence of these ESR1 mutations. And once they do, that they change the therapy onto this camizestrant, which is a SERD, which not only inhibits the estrogen receptor, but actually degrades it. The results from this trial are absolutely phenomenal. So patients where that they did detect these emergence of these ESR1 mutations have done significantly better than those that remained on standard of care. So this is a real clinical indication that these types of assays really work. Okay, so I was going to just briefly talk to you a tiny bit about advances in radiomics and machine learning. This is really fascinating. Another really good non-invasive way of telling us how our patients are doing, how they're responding to therapy, and to predict molecular subtype switching so we can change our management if the estrogen receptor is lost and you gain HER2 positivity. So radiomics can use either machine learning or deep learning algorithms, and they usually use pi radiomics to extract the data. So this can be used either on MRIs, which is really dominated in terms of response to therapy, ultrasound, which is looking mainly at risk recurrence, and mammography radiomics, which has really shown really good concordance in terms of predictability. So there's now, this has kind of come out of the study phase and is really starting to come in to clinical use. The remaining challenges are that there's few prospective studies, but that's now changing, and also that there is some interoperable variation. I won't go through that. That's just the workflow that one would go through for radiomics. And just to tell you a tiny bit about one or two studies. So this is what I was telling you about, that you can predict the molecular subtype using radiomics, and that's a really, really powerful thing to be able to do. And then lastly, I just wanted to talk to you about digital pathology. So this is one of our patients, and this is, you're looking at a brain metastatic lesion there. And what you're looking at is the ability of the cells within the brain to invade into the tumor, and that the communication that occurs between the brain cells and the tumor cells is completely different if the tumor is in the frontal lobe in comparison to the cerebellum. And it's only digital pathology that will be able to provide that type of information for us with any sort of great robustness. So AI has substantially improved biomarker scoring, especially in tricky situations which are now of clinical interest, like patients with HER2-low tumors. It's both foundation and generative models. So foundation models is where the pathologist will train the system, and then the system can go off and do it itself. And the generative models are when the system can come up with this all by themselves. So it's adding in new information, which is kind of scary, I suppose, as well. So we use it for clinical validation. It's really good at predicting late recurrence, particularly in estrogen receptor positive disease. These are becoming really good digital alternatives to genomic analysis. And really, in terms of areas of deprivation or in healthcare disparities, in places like Africa where there are low numbers of pathologists, this type of technology will be transformative. All you need is a scanner, and then you're away. So this is a really, really important area of growth, particularly in pathology. So I obviously won't labor you through these, but this is just in case you get the slides. So this is really what's hot and what's not in terms of digital pathology studies that happened in 2025. Sorry, in breast cancer. So this is it. This is two of our trainees arguing over who's going to recruit the patient and who's going to go to pathology to cajole the poor old pathologist to give us a sample. In terms of what's happening in the breast, ESR1 mutations, and our huge appreciation now for AI therapy and the consequences of long-term AI therapy. So our ability to see the emergence of these mutations and the ability to switch treatment strategies is going to be huge. HER2 expression, HER2 low, is completely hot. I don't know whether this is just pharma-driven to increase your patient population that can be given many of the trastuzumab iterations, but it's certainly gaining momentum. PI3 kinase mutations, because I remember every ASCO and every San Antonio I ever went, and all of these multi-omics would be taking place, and all we ever learned was PI3 kinase mutations are hot. P53 status and PD-L1 positivity, which I think is probably an awful lot more important in other tumors other than the breast, but is definitely here to stay. So these are just some of the trials that are really biomarker driven or biomarker informed. I told you about SERENA-6 looking at ESR1 mutations, but there's many, many more there. You can see HER3 beginning to gain prominence, and obviously like PD-L1, particularly in triple-negative disease. Lastly, I just wanted to put up this and just give you an indication of where in the world who's doing what, because when I looked at it, I kind of thought, does it tell us a little bit about our humanity? So the Americans are all chasing immunology. The Australians and New Zealanders are very interested in exercise and supportive care. And we're still looking at resistance and advanced disease. I think the biology is probably most exciting there, certainly from my own perspective. So I'm kind of glad in Europe that's what we're doing. Anyway, thank you.
So that's lots of food for thought, but because there's also lots of food for eating outside and we're running very late, we might scrap the 20-minute panel discussion and instead maybe take just one or two quick questions from the audience for our panel. But while you're thinking of those questions, I'd like to welcome Miriam Staunton to the stage, who's our patient representative. She's a cancer survivor and the chair of the UCAN Patient Advocacy Group. And just briefly, Miriam, after sitting through all of that, from a patient perspective, it seems to me that there's lots of exciting developments happening in how cancer is treated. Looking at the research, looking ahead, what things as a patient are you excited about? What are the challenges you see? And do you have any thoughts about what you've seen so far here today?
Thanks very much, Michael. Yeah, and I am conscious, obviously, that it's lunchtime and we're running late. So I feel the weight of trying to represent every patient here because it's the first patient voice we've heard today. So I think it's great to see so much going on, and that's so exciting. But I just keep going back to what Prof Naidu said this morning. You know, the kind of access to medications is why I originally got involved in Cancer Trials Ireland, seeing it as a route for patients to actually access medications. And I think it's so important. We see all the research and massive steps, and some of the presentations were so exciting to hear of, you know, step change in standard of care for poor prognosis of BRAF positive colon cancers, the move to neoadjuvant. But like for patients, what really matters is, you know, what's it going to mean for me? Like, what's this, you know, the so what? Like, what's the actual impact for me, my treatment, and my quality of life? A couple of points I want to make on that. We did a trial, I ran a survey last year with the support of Cancer Trials Ireland, and 96% of cancer patients are open to discussing trials. So we don't need to be afraid of talking to patients about it. Patients want to talk about it. But as Ken will probably kill me, but I always say, you know, putting the burden on the patient to just ask, that it shouldn't be. It should be the clinician bringing that to the table. So there's that. And then lastly, I just wanted to make the point, which, you know, we heard in the trainees' presentations this morning, which I thought were excellent, by the way, and their timekeeping was better. So, you know, what a recurring theme through that was the difficulty of accessing data, difficulty of accessing information, and you know, I'm excited to see what the, you know, proposed move to more in the electronic health space, record health space, will actually free up in terms of research and how much easier it should be to access data. And we can look to the north, our colleagues in the north are further down the path. And, you know, I was at a conference in Belfast earlier this week, the eHealth conference in Queens, and we've so much to learn from them, and they're just 50 kilometres up the road. So, you know, we should be just doing a copy-paste there.
Sometimes they're a bit tricky to understand.
And finally, it's just around the access to medications piece, which we have seen an indication from the state that they're going to improve the situation, which is great. But I think some of the research here is so important in terms of de-escalation, you know, a neoadjuvant where we can look to improved outcomes for patients, less treatment for patients, so less having to come to the hospital, and cheaper because, you know, we have to pay for less treatment. So I think that's all I wanted to say, but I just wanted to make sure I hit all my points. So hopefully everyone's ready to go to lunch now.
That's great. Thank you, Miriam. And I think it's very important that with all the research efforts that are going on, you have to bring us back to what effect it's going to have for the patient, that we can't lose sight of that. And well done for all your good work. Any questions from the audience for a wonderful panel, or is everybody hungry?
Ready for lunch.
I think everybody's hungry. I'd like to thank all our speakers today who've done a wonderful effort. I really enjoyed the presentations, and we'll be back on duty at 3 o'clock.